for having me today, and it's a pleasure to give you an overview on what's happening in kidney fibrosis. And I'm just going to cover a couple of this based on the subtitle, and trying not to bore you with too much of the mechanisms, and to touch a little bit on the novel therapies and to look into the global markets. I'll start with the slides, rather than the radiological imagings, and you could see that the right-hand side of yours is the normal kidney tissues, and the other one is a biopsy of a diabetic nephropathy patients that you could classically see. You can see them that the normal tissues are red and juicy, and you have these units of like glomeruli as compared to a scar tissues that predominantly stain green in color, and the whole tissues here, which is glomeruli, has been just filled by scar tissues. And kidney fibrosis is viewed as a a common pathway for all progressive kidney disease. And it virtually happens in all forms of kidney disease, such as diabetic nephropathy or transplant nephropathy, and even it's seen in aging as well. It is important, and because it's important for us to recognize that this is a common pathway. A kidney fibrosis eventually leads to chronic kidney disease, and the ultimate of that kidney disease will be people ended up in dialysis. If we look at the census of end-stage kidney disease over time in Australia and New Zealand, you can see that there is an increasing numbers of patients ended up in end-stage renal disease due to type 2 diabetes, as that in USA. And there's a static, however, of those non-diabetic kidney disease like glomerulonephritis or inflammations of the kidney disease and genetic disease as well. And strangely, you can see that the type 1 diabetes has remained very static. So the current course of end-stage renal disease is predominantly driven by diabetic nephropathy, and that's also potentially be one of the interests of companies and so on, so that we're looking at the therapeutic targets. The gold standard of treatment is to target on this renin-angiotensin systems, because kidney plays an important role in regulating salt, fluid, as well as blood pressure. By blocking these systems, it has shown by clinical trial as well as evidence in animal models as well that there are benefits in kidney disease and treating them. By reducing the intraglomerular blood pressure, help to reduce proteinuria, and that's lead to a prolongations of the kidney disease. And that has become the gold standard of treatments in any form of kidney disease, in particular in proteinuric kidney disease. However, if you look into the goals, the standard trial and this Renal trial, which is actually derived from that, and looking at how a treatment with losartan, which is angiotensin receptor blocker, as compared to a placebo in other in the diabetic populations, and how does it change in the outcome, which is end-stage renal disease. The red color will indicate that's of the losartan treatment group. You can see that there's a significant residue risk of people who are treating with this gold standard as what we see. And see here that at the 24 time points, there will be, the whole study shows that there's a 28% reductions of end-stage renal disease. However, if you look at a 36-month time points, the risk of people who are treated with losartan, it's nearly about 18%, and that, not treatments, is probably about 28%. So there's only a slight difference in terms of risk reductions, although translated into that is significant. And also you look at the duration as well. The treatment or not without treatments is only delay. You ended up in end-stage renal disease about 6 to 8 months. So there's certainly there's increasing needs for us to find other therapeutic options which actually can further delay, and perhaps targeting angiotensin systems is not just enough. And I think evidence have shown that we're repeatedly trying to block the systems, and it ended up with more problem. We need to look into something else, and certainly small molecule, other inflammatory processes, other process of fibrosis certainly need some place worth looking at. This is a picture that I used for my PhD when I look for kidney fibrosis, and it's quite useful. As Glenn mentioned, fibrosis is not a bad thing. I hope everyone going back from here is not going to think of like fibrosis is bad. We need fibrosis actually to heal. And it's a process that the imbalance between this injury and the repeated natures of it that actually lead to the bad things about the fibrosis. And genetic susceptibility is certainly one of the problems here. And there are other processes like inflammatory processes and hypoxic, particularly in the kidney, which is quite susceptible to it, that actually drive this process. And the renin-angiotensin system, I've mentioned, and TGF-beta. And the other ones is where the inflammatory process, where they lead to all these nuclear cells, inflammatory cells, and epigenetic modifications and the mitochondrial dysfunctions and endoplasmic reticular stress as well is also one of the key factors. I'll touch upon some of the mediator later. So this is just one of the genomic or nomic studies that it shows here that, you know, despite that there are various etiology of chronic kidney disease, but the chronic kidney disease associated pathway are quite shared among different disease. The yellow circle shows, you know, the disease like diabetic nephropathy, you have lupus, you have IgA. And the round non-colored shows a pathway or the target, and the line just indicate how it links. And you can see that how this is actually linked in the genomic studies, that both functional and disease manifestations, they're quite similar and they actually have linkage pathway. And that certainly means that, you know, whether we should actually think of like targeting a diseases only to one disease, or whether that could be, you know, more than the repurposing of certain drugs to more than just one disease itself. It's a busy slides, but I'm not going to again bore all of you. Just highlight some of the mediator that involved in the fibrosis. You can see that there are some on the inflammatory pathway, collagen depositions in the nuclear and the transcriptional factors point of view, and also the cytokine levels.
Is glomerular damage the biggest issue here? What about tubular damage?
No, I'm not only mentioning about glomerular damage. In fact, the glomerular only consists about 10% of the whole kidney. The rest of it is actually predominantly made by the tubules. In fact, our lab and Carol's lab, we're predominantly interested in looking in tubular because we believe that tubular scarrings are the ones that's actually responsible more for kidney fibrosis. And you could understand why, because you know, it's the majority component of it. And in fact, even in histological data, when we look into it, tubular fibrosis correlate better with decline in kidney function than glomerular sclerosis.
And do these conditions, do they manifest in different ways? So do different fibrotic kidney diseases, are some focused more in the glomerulus and some more in renal tubules?
There will be. Yeah. There are some diseases that predominantly affecting the glomeruli. For instance, like minimal change nephrotic syndrome. They only affect the kidney disease predominantly in glomeruli. And generally, they don't have impaired kidney function. However, it's a resistant form of kidney disease or nephrotic syndrome. Eventually, they can actually lead to impaired kidney function. That's a lot of talk about like whether that's because of the glomerular injury lead to injury of the tubules because of the crosstalk and the cytokines, and that has been certainly been proposed, and that's similarly in some of the heterogeneous lupus nephritis as well.
The question is how heterogeneous, for instance, is diabetic nephropathy?
It affects both glomeruli. It meant to be a glomerular disease, but because of it also, most of them will be associated with hypertensive disease. And because of the glomerular proteinuria, and the proteinuria causing inflammatory response of the tubules, you could say it is secondary to it, but I would think that they are you know, a similar disease that we need. These are just some of the therapy or novel therapies that which I pick a few that we already use in clinical trial. And just a glance of it, we can see that how many of them have failed, how many of them has been stopped, like a TGF-beta as a negative study, even pirfenidone in diabetic nephropathy, which shows initially to be quite promising, but the study has been withdrawn. The NOX1 and NOX2 as well is a negative study. Tranolone and its analog by Fibrotech is still in phase 1 clinical trials, perhaps one of the promising one. And anti-TGF-beta, one of the MCP1 inhibitions, which is which was presented in ASN about 2 years ago, shows that they have some effect in reductions of proteinuria, but certainly we require a longer terms of renal outcome. One of the study in clinic renal trial is quite challenging is because we don't really have an intermediate marker to determine the efficacy of your drug. We use protein, but unfortunately protein reductions or albuminuria is not accepted by FDA as a hard endpoint. We use eGFR reductions, we use reduction of kidney function, but that's to be translated to the hardcore renal endpoint, which is dialysis or death due to renal disease. Take a long time, and that's required a lot of investment, and sometimes to an extent is not practical because you need to wait 4 years to have like a 10 or 20 renal outcomes. It required a very long-term study.
Are we seeing any change where proteinuria is becoming more accepted as an endpoint?
Yes, there's been certainly a lot of publications and in terms of reductions of proteinuria. But at this stage yet, I do not think the FDA have approved it. But the FDA have accepted reductions of eGFR of like less than 30% or 40% as an accepted intermediate endpoint, hard renal endpoint for renal studies, but not proteinuria. But although this is still something that we use very commonly.
Some very loud noises, retrophins, sparsentan has been working quite closely with the FDA about reduction of proteinuria for certain orphan indications. Right?
We use that very often, but generally usually accepted as a secondary endpoint or a combinations of renal endpoint as a microvascular damage. And these are just some of the other ones which is in development, and I would like to touch upon some of the AdAlta, the collaborations that the lab that we have at Kolling with AdAlta, which also look at CXCR4 in kidney disease. We have shown, again, like what Glenn have shown, like in patients who have normal kidney tissues and the biopsy tissue, as you can see here in the diabetic kidney, there's increased uptake and staining of the CXCR4. CXCR4 is just a chemokine receptor that helps involve in inflammatory and attract a lot of inflammatory cells. And of course, by using an I-body, if we blocked it, theoretically, we should actually suppress it, and hopefully that can lead to a downstream reductions. We have also shown in different models as well. I think one of the challenges of also of kidney disease or animal models is you have chronic progressive kidney disease. You have also acute kidney disease like acute fibrosis like UUO, unilateral obstructive models, and we use diabetic models and folic acid model just to see different phases of fibrosis and where we see. And we also have been able to demonstrate that in proximal tubular cell that we could potentially bind, we have demonstrated the binding of this antibody.
And the acute models have an inflammatory infiltrate?
Yes, they will. They will also have, initially start with the neutrophil, but subsequently will be predominantly of the macrophages. As I mentioned,
in kidney fibrosis, is there any evidence of circulating fibrocytes contributing to it?
Good questions. There's always the questions. I think it's still a mystery, like where the fibroblast is coming from. There are lots of discussions about it, and EMT is one of them, which is part of my PhD looking at it. But I don't believe that I contribute more than what others have already known. And there are evidence of circulatory fibroblasts, and even from bone marrow, they have demonstrated UGFB label. There are cells of an endothelius from the bone marrow that eventually ended up in the kidney and helps in regenerations. I believe those are progenitor cells. There's also original residence fibroblasts, and there's now even recently discussions about endothelium that converted into fibroblasts as well. So I think, and kidney is just an organ that where you're going to have all the different derma of tissues that arises from, and that's make things a little bit more complicated.
So is there a belief that a myofibroblast is a key intermediate?
Yes, yes. Some of the challenges of clinical trial in kidney disease is patients are generally excluded from clinical trial when they have kidney disease. Anyone who have GFR of less than 30 will not be in the studies. And I think that concept will need to be changed. And there's also lack of intermediate marker, which I've already touched upon, or any biomarker or reliable biomarker that we could use. And it has a very high trial failure rate, as I've already shown you in some of the preclinical or clinical trials that half of them is actually not going to make up to the market. And certainly there's a lot of lack of coordinations between clinicians, scientists, and kind of the key holder. And for instance, one of the good examples is like erythropoietin that we've been used by the clinician for more than 10 years. But it took us 10 years to realize that, too much is not good. And it takes 10 years for us to actually do a clinical trial to convince the community that, that is actually harmful. And that's based on a lot of clinicians believe I used to do that, any doctor reports, and also general clinical practice. If 2014 is a year for lung fibrosis, 2016 is that for the renal fibrosis. And although I painted up quite gloomy for the clinical trial in renal, but Empagliflozin trial that's been published in end of 2015 have shown that use of empagliflozin compared to placebo in patients with type 2 diabetes significantly reduced the primary endpoint, which is a composite of mortality, cardiovascular mortality, and non-fatal MI and non-fatal stroke, predominantly driven by less than 30% of hospitalization, heart failure, and less than 30% relative risk reductions of cardiovascular disease and all-cause mortality. And not only that, it also translated to the empagliflozin groups has a significant improvement in the renal outcome. As you show here that there's a 39% reductions of incidence of worsening nephropathy, which is doubling of serum creatine and microalbuminuria. And this is predominantly driven by the new onset of macroalbuminuria. And if you can see that there is a 55% reductions of end-stage kidney disease. How good it is, I'm not sure. We have to actually see a little bit more. Whether this is just empagliflozin itself, whether this is a class effect, it's yet to be known. But that will be the next slide. I'm sure that will be asked. So empagliflozin is a sodium glucose transporter 2 inhibitions. It inhibits a glucose and sodium transporter in the proximal tubule, and it's actually causes glycosuria, you pee glucose. And with that, improved glucose control. But the trial that shown that the glucose control is so minimal that the effects cannot be explained by glucose control itself. And it also have the other benefit as well, because it also causes loss of sodium. And because of loss of sodium, it improves your water restriction, better water management, and also a mechanism known as tubular glomerular feedback, which it delivers less sodium to the distal tubules, and therefore it causes dilatations of the blood vessels, reduce intraglomerular blood pressure, and reduce proteinuria. And that's just a proposed mechanism. When you see so many of them, the proposed mechanisms that usually would tell that we don't know exactly which is the mechanism to be renal protective. But I think all of them make sense, and all of them have cardiac as well as renal. And you can see it also have reduced inflammatory and fibrotic component as well.
My guess would be the blood pressure angle there from the top is probably the most cardioprotective. What's your...
You could say that, but I could also look into the clinical data and say, well, there is a slight improvement in the blood pressure in the Empire trial. Again, and at the same time, the glycemic control as well. But it's not enough to explain that the benefit that you see in cardiovascular mortality as well as a renal outcome. Because if you compare to the other trial, which have a similar blood pressure reduction, they didn't show this kind of a benefit that you see. So there has to be something a little bit more than that. I agree with you. I think the natriuresis, in fact, a lot of people see the SGLT2 inhibitor as a diuretic rather than a glucose mechanisms. And there is another...
Even though they're indicated to treat type 2 diabetes.
That's right. And
that's the original.
Yeah, I wonder, and that's also an opportunity to look into whether we should...
SGLT1 as well.
Yes, this is SGLT2.
Yes.
Yeah.
Any information on SGLT?
Yes.
There's a couple of combination SGLT1, SGLT2 inhibitors coming up. Is there any information on that?
It generally, you have predominantly the glucose and sodium transporter by SGLT2. And when you inhibit SGLT2 inhibitor and you get an overcompensation SGLT1, the effects of SGLT1 is not as remarkable in terms of sodium, sodium regulation point of view. So I'm uncertain about binding both is going to be helpful, but room for improvement. And there's another one which is liraglutide, which is a GLP-1 agonist. Is another diabetic medications, you need glucagon, which is a natural intestinal hormone that stimulates your insulin productions. And DPP4 is an enzyme that breaks it very quickly. So it's almost like second you have this GLP that get destroyed. So you can either block DPP4 or you could either give patient GLP, which is an agonist for the glucagon. So this is another trial, about 9,000 patients looking at diabetic patients of high risk treated with liraglutide, but this is given in the form of weekly injections, daily injections, sorry. And also shows that there is a significant reductions of primary endpoint, which is a similar mortality, and predominantly that was driven by the cardiovascular outcome. And in these studies, they also show that there's a reductions of new onset of albuminuria and proteinuria, similar to another study, but they also demonstrate the worsening of retinopathy. So I think the benefit of the drugs on microvascular complications are yet to see. And although they're all very promising, I think both of the studies, we're not sure whether just due to one study, one drug itself, or is a class effect. And there's a credence trial, which is a canagliflozin, will also be specifically addressing on this part. Just a few words on projections, like when we see, again, dialysis, which is what we fear. And if you look into the projections the analysis done by the George Clinical, like in 2030, there will be 5.4 million patients who are going to be on dialysis. And you can see that the numbers are going to be predominantly driven by the Asia Pacific, which is very, very large in number. And this is only form of fractions of what we see in patients with chronic kidney disease. This is the endpoint. In fact, most of the patients don't end up with dialysis. A lot of them die before that. And I think this is what we're trying to avoid. We should try to target interventions much earlier, when they're a stage 3 CKD, rather than when they're stage 4 and stage 5. And there's also a global push that we need to find more therapy. And this International Society of Nephrology have formed working groups, in fact, several working groups that are trying to look for like novel therapeutic. And there are 4 main goals to identify like druggable targets and encourage collaborative studies, increase investment, encourage preclinical. In fact, I think this is one of the aims, that preclinical and early clinical development, and broaden kind of the approaches in terms of like therapeutics. So there's certainly a push. Although you must be wondering why the clinician talking about global market, I'm just going to run past this very quickly. But I thought, again, as a good slides in the sense that like the decision resource group looking, again, do a projections in 2020, in 10 years' time, how much money or what's the market is like for a chronic kidney disease, and it actually reached by 11.7 billion as compared to like 11 billion in 2012. And that's predominantly, again, focusing on stage 4 and stage 5 kidney disease, like erythropoietin, phosphate binder, dialysis patients. And although they did mentions about like emerging CKD therapy, but the amount of the potentials looking into this 6 country, perhaps again need to looking and shift back to like early interventions. And that take into account, the analysis actually take into account the offset of the increasing cost of like this patented drug, like loss of genetic drugs, but it doesn't take into the account of like failed therapy. And certainly the HIF-1 alpha inhibitor will be something that worth to watch out in the next couple of years, and there's a couple of clinical trials actually going on. So there's certainly, I hope I have convinced you that there's unmet need for like new therapeutic options for kidney fibrosis and what kidney fibrosis is about. And there's a global recognitions and demands as well, and commercial opportunity. It is important to look for novel targets, but also clinical translations. And there's also a need to look for whatever we do, we need to have some degree of hard renal outcome, like a 6 months proteinuria reductions. Perhaps it's not quite enough. We need to look a little bit harder. And a more collaborative effort like what we have done with AdAlta will be something that I think need to be strongly encouraged. Thank you. Any questions?
Did you transplant kidney for fibrosis?
Oh, yes. I mean, when patients ended up with end-stage renal disease, That's the ultimate point of fibrosis. And the only way to replace that is to do a transplantation to replace the kidney function. So we do that.
So similar to the lung story.
That's right.
Do you see regeneration of it?
Depends on most of them is actually doing quite well, but there are recurrence of the disease, like IgA nephropathy can recur. There are certain one like idiopathic focus segmental glomerular disease, which is a hereditary form of disease, can occur. Like Fabry sometimes can occur, but most of them do quite well. Like I think the concept of transplantation certainly offer much more benefit in terms of cost, survival, quality of life as compared to dialysis. So even if you can give someone like 10 years of kidney, it will be much more better than for someone who is going to be on dialysis for 5 years.
So it seems to me that this is a bit of there's a huge unmet medical need here, but it's a kiss of death trying to develop drugs in a space where you don't know what to measure and how that relates to a meaningful impact on patients. And you've just given 2 examples of drugs and drug development that were developed for treating type 2 diabetes, and secondarily you're seeing some protective effects in the kidney, which is probably why it's not attracting a lot of industry into doing a lot of these drugs.
I mean, it's a fair comment, but at the same time as well, I think the industry is predominantly, I think everyone is looking at cardiovascular outcome, which is a must, I think, for FDA approval. But we should also looking at more of an increased renal outcome trial. Like a Credence study is one of the very good example where predominant focus is going to look into renal. Of course, they also have cardiovascular outcome. And I think there should be a change of attitudes in terms of investors and clinical trialists as well that, kidney disease, we really need a lot more evidence. We need more clinical evidence, and we need drugs. And how are we going to develop that? Of course, measurement, it is a challenge, I have to say, but we need to, but it doesn't mean that we cannot overcome it. Like we could use GFR, we could use supplementary eGFR, and they are albuminuria. They are not hard to do. They are not like you need to do a biopsy all the time. But it is important to understand that we need long-term outcome. And a lot of this renal trial at the moment is we are looking at a finite durations of acceptable FDA approval outcome, and then follow up those patients for long-term to look for a hard renal outcome. And
is it easy enough to diagnose patients early in a kidney fibrosis?
Yeah.
It is?
No. I think the...
So you get patients with their late stage, like...
That's right.
Like
that's right.
Pancreatic cancer.
That's very true. 80% of the people, in fact, 1 in 3 Australian will have more than 25 years, will have 1 risk factor or 1 clinical manifestation of kidney disease. 1 in 10 will have 10 risk factor. But 80% of this, unfortunately, is silenced. Nobody knows about it until they're presented much later with a blood test and a urine test. So there is actually a lot of needs to look into, like a marker to look into. And in fact, I did actually look into some of the marker like BNP and TGA-beta as a marker circulating factor in diabetic, and I published that. And we need to also look into like some other way that could predict people that have a chronic kidney disease.
So you can treat them early, right?
Yes.
What about simple blood markers like BUN and creatinine?
We generally use BUN, creatinine, which translate to GFR,
Yeah.
and urine will be urine analysis for any active sediments. That will be a 2 simple tests that probably everyone do that every year.
Yeah.
Yes, for a screening. But the problem with using this is like when you actually have microalbuminuria or urine in your protein, you already have established diabetic nephropathy or kidney disease. You already have scarring. I think we should look a little bit further than that. Of course, there are discussions and there are arguments about which is better. Like we already have existing one. Why something further? Because even if we intervene right now, we still see patients progress, and we probably need to look a little bit further behind. Thank you.